Medurstand Understanding Medicine.
I'm Professor Azizur Rahman, and we are continuing our lecture series on valvular heart diseases. We have one lecture on basic introduction, and then one on mitral stenosis, one on mitral regurgitation, and one on aortic stenosis. And this is the next in line. We are going to discuss uh, aortic regurgitation. Now, this is the cartoon of aortic regurgitation. You can see in this picture, this feather-like jet is actually the blood which is regurgitating back from the aorta to the left ventricle. And normally this should never happen because during systole, the aortic valve opens, and during diastole, it closes almost completely. There is no significant regurgitation, but if aortic valve is abnormal, is not closing during diastole, it would allow blood to come back from the aorta to the left ventricle. You know, in the aorta, pressure is fairly high during the diastole, like 80 millimeter, 90 millimeters. So there's a lot of pressure. And during the after the systole is over, during diastole, the pressure in the left ventricle is close to zero, maybe only slightly on the negative side also. So negative zero here and 80 here, that will allow a lot of regurgitation occurring. But please note down, as the blood is coming back from the aorta to the left ventricle, pressure here is reducing and pressure here is building up. So the gradient is reducing. So whatever regurgitation occurs, it usually occurs in the initial part of the diastole. So that would be important when we discuss the murmur of this condition. This is an actual echo. You can see that this is aortic. This is the aortic valve. I think if you can appreciate this structure like this, two cusps uh, joining each other in the center, and this is aorta. Blood is coming back, and this blue jet indicates that there is regurgitation. So this was the basics of what aortic regurgitation is. Now we are going to discuss its various features. Now, the etiology in aortic regurgitation could be rheumatic. I think the rheumatic remains the commonest in aortic valve regurgitation. And if there is rheumatic etiology, it is very likely that patient would have additional aortic stenosis and certainly mitral valve disease also. If somebody has pure aortic regurgitation with no stenosis and mitral valve without any involvement, it is very likely that this is not rheumatic then. It may be Marfan syndrome. Marfan syndrome is a congenital disease where there is some problem with the connective tissue, and since these valves consist of connective tissue, they are weak and become regurgitant. Endocarditis could cause valve damage and result in regurgitation. Syphilis used to be a common cause, but luckily not anymore. And degenerative disease processes, they can damage aortic valve. Typically, those patients who had this bicuspid aortic valve disease, with the time, they actually end up having a significant stenosis or regurgitation or combination. So etiology is important, but perhaps our treatment is not focused on etiology. Whatever the etiology is, the treatment is based on the degree of stenosis and the symptomatology and the complications. The symptoms of no specific symptoms of aortic regurgitation, except that these patients, they complain of lot of palpitation. Why? Because in aortic regurgitation, there is significant increase in cardiac output. Now, because left ventricle contracts and half of the blood goes back to the left atrium and only to come back into the left ventricle during the next diastole. So left ventricle is overfilled. Left ventricle is under volume overload. Left ventricle receives more blood than its usual share. So left ventricle contracts with greater force, leading to increased systolic pressure, reduced diastolic pressure, increased cardiac output. So that is why these people, they have this palpitation. Ultimately, when the heart fails, then there would be dyspnea also, but dyspnea is usually a late symptom because left ventricle has got lot of adaptability and lot of compensatory efficiency. So that is why initially just palpitation or asymptomatic person, later on patient would develop dyspnea. The physical signs of aortic regurgitation: collapsing pulse. Now this is very important, and let me first clarify, explain what is collapsing pulse. You examine the pulse like you normally do, and you notice that the pulse is high volume, and if that is the case, one of the possibilities of high volume pulse is collapsing pulse. Then you do the proper method. The proper method is that with the other hand you make a fist around the wrist and feel the radial pulse. I'm doing on my own hand. So you will feel the radial pulse and then concentrate for a while and try to register the volume of the pulse. Then using the other hand, you raise the arm like this. You of course use your other arm to raise your arm. You examine the patient. So when you raise the arm, guess what happens? The volume increases further. That is the hallmark of collapsing pulse. The collapsing pulse is the pulse which is high volume to begin with, but when you raise the arm, the volume increases further. I remember many times students saying when you raise the arm, the pulse collapses, like the pulse disappears. No, it is just the opposite. Pulse actually increases in volume. And let me explain why that happens. Now, first we have to explain why there is a high volume pulse in aortic regurgitation. You know, in aortic regurgitation, because left ventricle stroke volume is increased. Why so? Because left ventricle is receiving double the venous return. First, the one which is coming from the pulmonary circulation from the right side and then through left atrium into the left ventricle, plus the blood which had regurgitated back to the left atrium only during the previous diastole. So the venous return to the left ventricle would be increased. And you know the Starling principle. If the venous return is increased, if the ventricle is otherwise healthy, it will contract with greater force and will produce more stroke volume. So more stroke volume will increase the systolic pressure. So that means the systolic pressure has gone up. Now, during diastole, what happens? Normally, blood stays in the aorta and gradually goes forward. It never goes back to the ventricle. So it takes time before the aorta gets pushed blood into the circulation. In cases of aortic regurgitation, what happens is blood goes back to the left ventricle because the valve is not closing, the valve is incompetent. So that leads to sudden drop in the diastolic pressure. So there is increase in the systolic pressure, we have already learned, and there is drop in the diastolic pressure that will widen the pulse pressure. You know, pulse pressure is the difference between systolic pressure and the diastolic pressure. So that increase in pulse pressure will directly correlate with the pulse volume. Increased pulse pressure means increased pulse volume. So we have explained why pulse volume is increased in people with aortic regurgitation. Now the second component, how and why it increases when we raise the arm. You know, when we raise the arm, because of the effect of gravity, the amount of blood which regurgitates back into the left ventricle during diastole, when you raise the arm, that actually increases. So more regurgitation means further drop in diastolic pressure, and more regurgitation means more stroke volume in the following systole. So increase pulse pressure even more than what already was. So the stroke volume, which was high to begin with, by raising hand, the stroke volume increases further and pulse volume increases further. So this is collapsing pulse. This is characteristic of aortic regurgitation, but there are some other conditions where you can see this pulse. I'm going to, I think, give you the list of those conditions also. And then there is heaving apex beat. That means when you put your hand on the your hand on the precordium, you will see the hand is lifted. But unlike the heave we discussed in aortic stenosis, which is sustained heave, in this case it is ill-sustained heave or non-sustained heave. Your hand will be lifted, but it will then go back because there is no left ventricular outflow obstruction. So left ventricular systole is not prolonged. So the systole is normal. That is why it is not sustained, but it is heave. You have very, very significant feeling of lifting your hand because of increased left ventricular stroke volume. Then there is a murmur. This murmur is early diastolic. Remember I explained if there is regurgitation, if the aortic valve doesn't close, only in the initial part of the diastole there is significant pressure gradient between aorta and left ventricle. With time, after a few milliseconds, as the blood is coming back from the aorta to the left ventricle, the pressure in the aorta is coming down and the pressure in the left ventricle is going up. So somewhere during the middle part of the diastole, the pressure equalizes and no more regurgitation. So there is murmur, which is early diastolic up to the middle of diastole. It is not heard in the later part of the diastole. Plus at decrescendo, that means it is of maximum intensity to start with and gradually reduce in the intensity. It is usually very soft. Unlike murmur of aortic stenosis, this can be easily missed unless you are a very careful examiner and you examine the patient very carefully and you examine in a quiet environment. You can definitely miss this murmur. I think good way to not to miss this is that if you go methodically, if you have already examined the patient like you normally should, you have examined the pulse and you have checked the blood pressure. Blood pressure will also record high systolic, low diastolic. By the time you examine precordium, you should be already anticipating this murmur. So if you're already anticipating something, you are very unlikely to miss it. So I think that is the best way to go. If you're not anticipating, if you had not taken blood pressure, if you're not checked the pulse, then I think during auscultation, you can miss this murmur. This murmur is best heard on aortic 2, which is the left part of the sternum, third intercostal space. If I'm not wrong, second or third, I think it's the third intercostal space. And this is best heard with the diaphragm of the stethoscope and when patient is bending forward like this and is holding his breath during expiration. So of course you have to be very quick in examination. You ask the patient bend forward, take an inspiration, then do expiration and hold the breath there, and that is the time when you pick up this murmur. And there could be another murmur which would be functional murmur. This is called Austin Flint murmur, of course after the name of a scientist who described this murmur. When there is a regurgitation of blood from aorta to the left ventricle, then the blood is passing in front of the anterior mitral cusp. While it passes across the valve, it puts the valve into vibration. So that causes a murmur which is arising from the mitral valve in the middle part of the diastole, and it is arising from the mitral valve. So it could be confused with murmur of mitral stenosis, because there could be actual mitral stenosis in patient with aortic regurgitation if this is rheumatic. So echo will tell you if this is functional murmur or if there is additional mitral valve disease. So I think that is the auscultatory part. Now this is the graphic representation of the same. First sound, second sound, no sound in the systole, but there may be a functional systolic ejection murmur. Why? Because there is increased stroke volume. Even if aortic valve is not causing any obstruction, but because of increased stroke volume, there may be a faint systolic ejection murmur here. But typical murmur of aortic regurgitation is this uh, decrescendo murmur, which is maximum to begin with, but it decreases in intensity, and by the middle of diastole, it just vanishes because the pressure in the aorta and the pressure in the ventricle, they equalize. So this is the murmur of aortic regurgitation. Differential diagnosis of collapsing pulse, you could see it in arteriovenous fistula, and there could be naturally existing arteriovenous fistula. It may be surgically created for patients who undergo dialysis, or it may be effect of some trauma. If there is arteriovenous fistula, meaning that a main artery directly communicates with the vein, that may result in some hemodynamic changes which would cause collapsing pulse. Patent ductus arteriosus may also cause collapsing pulse. Paget's disease of bone, because there is a lot of vasodilatation that can cause collapsing pulse. Hyperthyroidism will cause at least high volume pulse, and anemia will also cause high volume pulse. So these are the conditions which can cause a pulse which will be similar to pulse we see in aortic regurgitation. But I think we always say that if you have classical collapsing pulse, it is very likely that this is a case of aortic regurgitation rather than any of the other conditions listed here. Diagnosis is clinical. Clinically, you should suspect it, and collapsing pulse should lead to the diagnosis, and then presence of early diastolic murmur will confirm the diagnosis. X-ray chest should show cardiomegaly of left ventricular type, because that means apex moves leftward and downward. ECG will show left ventricular hypertrophy, and echocardiography is the final diagnosis. It would tell you if there is any additional pathology like mitral valve, and if there is any clot formation, calcification, or anything. So echo is, of course, the final test. Treatment may be just wait and see. If patient has regurgitation and patient has got well preserved left ventricular function, you could see, at least you could wait for some time, but ultimately patient would require some kind of intervention, and I think a valve replacement would be needed in many patients. Like I discussed in previous lectures, this valve replacement could be prosthetic or could be biological. Now, this rheumatic process actually it damages the valve, and valve has got only two function, opening and closing. So many times both are affected, and many times you have combined aortic stenosis and aortic regurgitation. If you have combined aortic stenosis and aortic regurgitation, it is likely that it is either rheumatic or congenital. The other etiologies are less likely then. And then you will have two separate murmurs. This is the systolic ejection murmur of aortic stenosis, we have discussed in detail. This is the early diastolic murmur of aortic regurgitation. This we have already also discussed. Both would be heard in a different areas with different radiation, with different characteristics. So you will be able to tell that there are two actually murmurs and with their own features. So if both are present, it would mean the patient has got aortic stenosis and aortic regurgitation. By the way, if somebody has combined lesion, there would be Bispherian's pulse. In aortic stenosis, we have anacrotic pulse. In aortic regurgitation, we have collapsing pulse. And if we have combined aortic stenosis and aortic regurgitation, we may have what we call Bispherian pulse, which has features of both, which has like a prominent notch and a not that high volume but a notch. That is anacrotic. That is Bispherian pulse. So that was it. This was a relatively brief account of aortic regurgitation. I hope this will help you to understand this disease better and able to perform better in your bedside examination and in your clinical practice. And hope you are able to pick up this condition, make a clinical diagnosis, later confirm on echo, and do whatever is needed, not wasting time, because in these conditions, in all medical condition, I guess time is the money, and if you make the diagnosis early, you can offer the treatment early, that would change the prognosis completely. This was Professor Azizur Rahman from Medurstand, and the next lecture would be like a quiz, because we have covered the entire spectrum of valvular heart disease, and now we will have two quizzes covering these conditions that will not only test your knowledge, this will actually allow you to test your own knowledge. I'm not testing your knowledge, so, and not number one, and number two, it will allow us to have some revision to discuss some important aspects. So don't miss, you have attended all four lectures on valvular heart disease. Please attend the last one also, the one on quiz. The quiz is very interesting. Looking forward to see you there. I'm Professor Azizur Rahman from Medurstand. Thank you.